Welcome everyone to the December episode of the CNS Journal Club podcast. I'm Jeffrey Traylor. I'm a PGY3 resident here at UT Southwestern Medical Center in Dallas, Texas. I'm joined here with our guest faculty as well as our authors. And today we'll be discussing the study Concurrent Administration of Immune Checkpoint Inhibitors and Stereotactic Radiosurgery is well tolerated in patients with melanoma brain metastases, an international multi-center study of 203 patients. So I had the privilege here of being joined by two of the authors from that paper, as well as our guest faculty. And so we'll start off with some introductions. Dr. Patel, would you mind introducing yourself for the listeners?
Yeah, thanks very much for this opportunity. My name is Toral Patel. I'm a neurosurgical oncologist at UT Southwestern. I'm an associate professor of neurosurgery and director of the UT Southwestern Brain Tumor Program.
Wonderful. And Doctors Lehrer and Trifiletti, we'll start with you, Dr. Lehrer.
Hi, well, thank you for having me this evening. My name is Eric Lehrer. I'm a PGY5 chief resident at Mount Sinai Hospital in New York City.
And last but not least, Dr. Trifiletti, would you mind introducing yourself for us?
Yeah, I'm Dan Trifiletti. I'm a radiation oncologist. I'm at the Mayo Clinic in Jacksonville.
Wonderful. Well, thank you all so much for joining with us today. I think we're going to have a good discussion. Doctors Lehrer or Trifiletti, however you'd like to split it, how about you just start us off with a summary of this work before we start getting into questions?
Sure. Yeah, I could do that. So this was a multi-center retrospective analysis. We conducted it through the International Radiosurgery Research Foundation, and we looked at a subset of patients with melanoma brain metastases who were treated with stereotactic radiosurgery and with immune checkpoint inhibitors. So we had a total of 203 patients. There were roughly 1,400 brain metastases. 11 international institutions in 4 countries provided data. Median follow-up was 15.6 months. And what the goal of the study was, we wanted to characterize the risk of radiation necrosis, both any grade and symptomatic radiation necrosis by therapy timing, meaning the amount of time between checkpoint inhibitor and radiosurgery administration. So we looked at that by comparing concurrent to non-concurrent therapy. So in line with previous literature, and I'm sure we'll get into this a bit, we defined concurrent administration as administration of radiosurgery and checkpoint inhibitors within 4 weeks of one another. On the multivariable analysis for any grade of radionecrosis, so anything from symptomatic to pathologically confirmed necrosis, we saw that patients with a V12 greater than 10 cc's, including the target volume, the presence of a BRAF mutation, and prior whole brain radiotherapy were actually associated with an increased risk of developing radionecrosis. We're looking at just the symptomatic patients. The V12 greater than 10 cc's was still a predictor, and as was a BRAF mutation, but whole brain radiotherapy no longer was. So we didn't see any increased risk of any grade radionecrosis or symptomatic necrosis in patients who received concurrent therapy versus non-concurrent therapy.
Yeah, and I'll just add that the context for this for people who aren't following the radiosurgery literature closely is that stereotactic radiosurgery has a long track record of safety and efficacy in the setting of brain metastases, but advancements in drug therapy, specifically immunotherapy, and the more common use of it over the past 10 years really have called into question the safety and potentially that when administered with radiosurgery, the risk of radionecrosis or symptomatic peritumoral edema following radiosurgery could be increased. And there's been a few reports in that regard. So this effort was a collaborative effort across several institutions throughout the world through the Radiosurgery Research Foundation to enumerate that risk and to look to see if there's predictors and how real it is. We chose melanoma specifically because immunotherapy is commonly indicated in that condition with current guidelines.
Wonderful. Thank you both so much for that wonderful summary. Dr. Patel, did you want to start us off with some questions so we can get a discussion going?
Yes, I'd love to. Thank you. Thank you again for the opportunity. Eric and Dan, I thought this paper was really fantastic and answered some very important questions for modern practice radiosurgery and modern cancer care. I sort of had a lot of interest in the fact that V12 over 10 cubic centimeters was a significant predictor for increased risk of radionecrosis. Certainly, we sort of have that flavor and knowledge when we're doing radiosurgery in general, but it was nice to see that enumerated in this manuscript. What do you guys think about the role of either hypofractionation or neoadjuvant SRS as a mitigation strategy for lesions in which you know that the V12 is going to be greater than 10 cubic centimeters with a single fraction approach?
Sure, that's a great question, and thank you for your kind words. I'm really nice to hear you enjoyed our paper. So, in terms of hypofractionated radiosurgery, multifraction SRS was an excellent mitigation strategy, particularly for larger lesions. And in my institution, we commonly will do 27 gray and 3 fractions. That's probably been the most well-validated fractionation scheme. The 2 Minetti papers out of Italy in both the intact and the adjuvant setting. And sometimes we'll do 30 gray and 5 fractions as well if the lesion is a little bit larger, if there's a lot of edema, if it's located in a eloquent location. That's also an excellent approach. I think the Alliance trial, that they're looking at postoperative cavities, it's using those 2 fractionation schemes. I think Dan could probably confirm that. I think Mayo's actually opening up something looking at fractionated radiosurgery for intact lesions. In terms of pre-op SRS, I know Dan's the expert in that, but I'll say briefly, I think it has a lot of promise. The data are very strong, suggesting that have shown actually that the local control is comparable to postoperative therapy. You have a lower rate of nodular leptomeningeal disease. It's also easier from a technical standpoint to target an intact lesion versus a CTV when you're dealing with a resection cavity. How much of the tract to include, how much of the adjacent dura to include. Things like that. Also, you have to worry about things like cavity dynamics. So I think both are appropriate, are definitely appropriate mitigation techniques.
Yeah, even you asking those questions got me excited about the future of radiosurgery for these complex situations. I think that hypofractionated radiosurgery and neoadjuvant or preoperative radiosurgery are both super promising opportunities to improve tumor control and reduce side effects. A challenge that we currently have is when to use it, and there's several studies in this space. So at Mayo, we have 2 randomized trials that are open on each of those questions. So single versus hypofractionated radiosurgery for like big-ish tumors, over 2 centimeters. And also preoperative versus postoperative radiosurgery. There are several other groups doing this. I know MD Anderson has some trials open, and then the NRG has just opened a trial for preoperative versus postoperative, which should be considered at institutions of those people listening. But a challenge, if it is shown to be better, the nice thing about single fraction radiosurgery is that, as you mentioned, V12 is a really well-established metric for radionecrosis. It's been well tested. It's very common in the literature. We don't have similarly robust metrics for hypofractionated or preoperative radiosurgery. One good question is, what's the right dose to treat a preoperative brain tumor with radiosurgery? In the existing literature, Eric also mentioned that eloquent brain location may be a factor that helps us push us one way or the other, and it should, although that's not as well delineated or measured in the existing literature. And specifically, the way we calculate V12 can sometimes include the calvarium, the volume of the calvarium receiving 12 gray, depending on the metric you're using to measure it by. So there's a lot of room for improvement in how we're even measuring V12 specifically, and then how it applies to these other fractionation schemes and treatment strategies. But it's super exciting as an open area for research to improve the care for future patients.
Awesome, wonderful. I'll shift gears a little bit. I hate to do that, but we have a limited amount of time. I read with interest, that 10 to 15% of the patients in this cohort had some type of radionecrosis, whether it was symptomatic or not. And so that's a relatively robust sample size. And review of the literature shows that some patients who experience these transient increases in lesion size actually do better in the long term. And everybody's sort of wringing their hands when the MRI looks a little funny at 6 months or 9 months or 10 months. But if the patient can get over that hump, there's literature to say that those are the ones that perhaps in fact do better. And maybe it's because that pseudoprogression or transient lesion change is because of some inflammatory infiltrate that suggests that the immunotherapy is quote unquote working. And so I wonder what you guys think about that, and having seen that in a reasonable percentage of your cohort, do you have any sense for how the survival was for those patients versus the rest? I realize the study wasn't targeted towards that, but maybe you saw that data in the background.
So that's this is a topic that's very near to mine and Dan's hearts. So we didn't look at survival based on the comparing the radionecrosis cohort to the non-radionecrosis group. But just a couple of points about that. So it's incredible. So the vast majority of these cases are imaging defined radionecrosis, which is an incredibly difficult and heterogeneous endpoint to measure. There certainly are MRI findings like a tumor board. We'll often hear the neuroradiologist refer to things like a soap bubble appearance or perilesional edema, but none of them are really very specific. So, it's very hard to elucidate what exactly these imaging defined necrosis cases are, and they make up the vast majority of the patients. But I know this isn't the focus of this talk. We recently published another paper looking at melanoma, non-small cell, and renal cell patients. And when we compared, and these are all imaging defined necrosis cases, and when we compared the survival, the patients who developed a imaging defined necrosis event actually had a 6-month longer survival. I personally don't know if survival is necessarily longer. I mean, I don't know if this is the best data set to say that for sure. It might be a little bit challenging, but I think what it does show, what the bigger message is, that this is a very hard endpoint to measure, particularly in the setting of modern systemic therapies. So we need to find better, radio tracers and other imaging modalities to actually determine what's going on and if this is actually true necrosis or just a sign of a better systemic response to immunotherapy and radiosurgery.
Perfect. Keeping on that survival theme, your manuscript showed that there was better overall survival for patients who received concurrent ipi-nivo, and I assume that the mechanism is believed to be some increased anti-tumor immunity from that combination therapy that was delivered concurrently with radiation, that there's some synergy there. But besides sort of that logical assumption, is there a biomarker that can be assayed to quantify this? Is there a biomarker that's under investigation for us to quantify this in the future? Something beyond sort of logic to say how robust a patient's immune response is to ipi-nivo and what we might anticipate their brain activity to be.
So I know there's a lot of research going on now looking at tumor mutational burden, DNA repair pathway biomarkers. Those are presently being investigated. Particular actual, like a biomarker that's been well validated, I don't believe there is one particularly, that we use in this setting. Particularly in, within the brain, which is, I think we'd all agree the brain is a bit, more unique than the rest of the body. But it's a great point. We certainly do need biomarkers to actually determine if we're actually enhancing the tumor, if we're actually priming anti-tumor immunity in response to these two therapies.
Yeah, I think functionally for those in the clinic, PD-1, PD-L1 is probably the best thing we have now. And that's probably pretty good, but there's plenty of room for improvement from there.
Perfect. I read with interest that on the univariate analysis, those who received ipi monotherapy had an increased risk of radiation necrosis, while those who had combo ipi-nivo had a lower risk of radiation necrosis. I found that slightly curious, but I wonder if that's because there was a dosing difference between the ipi monotherapy cohort and the ipi-nivo combo cohort. I don't know if this study had the granularity to understand if there were dosing differences. I realize that it's hard to dig through oncology charts and figure that out at every point in treatment for patients. But I wonder if you do know any of that data, or if it is simply, it's a black box.
So that's a great question. So this actually, so no, we don't have that, that level of granularity of the data, but I do believe I would have to double check. I don't think we didn't see an overall dosing difference between the arms, the concurrent and non-concurrent. We didn't look at it by checkpoint inhibitor agent used. However, what we think, and this actually ties into one of the findings that I thought were very interesting, was this BRAF, the interaction with the BRAF mutation, the role of the BRAF mutation, what we observed in our outcome. So there might be a little bit of confounding going on. So we actually saw that the BRAF mutant patients, I know we're going to get into this a bit, they had a higher rate of necrosis. And in the ipi-nivo arm, there were actually more BRAF mutant patients in the ipi monotherapy arm than in the combo therapy arm. So what we actually might be seeing is the effect of the BRAF mutation. It's a possibility.
I think that's a great explanation, and it is a great segue into my final question, which is, although not the main focus of this manuscript, clearly builds on this idea of how do we time targeted therapies, immunotherapies effectively with SRS, and although you didn't have perfect data about whether patients were on BRAF inhibitors or not during the time of their radiosurgery, there was some inference made based on their BRAF mutation status. And that is a nice explanation for why, if the ipi monotherapy arm had more BRAF mutant patients, that they may have been on BRAF inhibitors around the time of radiosurgery. And so can you comment on what is your, Eric, Dan, personal belief about BRAF inhibition and timing of SRS? Is there something that this audience can sort of take home as a salient point on that?
So that's a great point, and I want to hear what Dan thinks as well. So there's been a few studies done out of the Cleveland Clinic that actually do show, about 5 or 6 years ago, that when anti-BRAF agents are given concurrently with radiosurgery, there's higher rates of radionecrosis, and I think they also saw that by holding the BRAF, and I'd have to double check, but I think they didn't see a worsening in outcomes if they were to hold the BRAF agent for a prolonged period of time. At my institution, when we have patients with, a lot of these patients that are on anti-BRAF agents are now being observed. So we're not seeing as many of them, but when we do, I would say we typically will hold their therapy probably for about a week. That's typically what we do where I am. I don't, that's just our experience.
Yeah. Similar. I think it probably is more pertinent for whole brain radiotherapy in patients with combination BRAF inhibitors, but for radiosurgery, I think the European group came out with a consensus statement to hold it for a day for safety, but it wasn't based in particularly strong data. In my mind, this question really personifies a problem that we have in the modern radiosurgery clinic, which is the drugs and the targeted agents are coming out faster than we can study them well. And if it's not being done prospectively, and then the drug's approved and then it's used quickly, and it should be, and then we're kind of left to decide how to manage these brain mets. More is more, and so more treatment is going to cause more risk, particularly when there's synergy between the therapies. So I think it's a challenging decision to make, and it's a challenging decision to be left in the hands of medical oncologists alone, and really requires brain directed experts who can say that's in a high risk lesion for these reasons, or a low risk lesion for these reasons, and that could be treated with drug therapy alone, or that should be treated with radiosurgery, or maybe these tumors should be treated with radiosurgery but not those. That kind of is sort of a faux pas thing to do in brain tumor management, at least in the radiation oncology world, to treat some but not all of the tumors. But that sort of thinking is it's what I would want if I was a patient. Treat my 2 centimeter, 3 centimeter tumor, but let's watch the other ones on drug therapy and see what happens. I think that kind of thinking makes a lot of sense to me, but it's just not really what we do for historic reasons. And so the challenge that I have is we're never going to know. We're never going to have prospective randomized studies, to evaluate the timing of these, sort of esoteric targeted agents in these diseases, it's just not going to happen. And so we're kind of left as clinicians to use our best judgment. And that's kind of the art of medicine. And why what we're doing is different than just reading the NCCN guidelines or textbooks. So to answer your question, I think the risk is probably more, and it's believable that it's more, but in people with expertise on this topic and expertise with neuroanatomy and multidisciplinary teamwork, there's an opportunity to be sort of appropriately aggressive and take calculated risks in a way that's meaningful to patients and helpful to them in a context where we'll never have all the perfect answers.
I wanted to follow up on the discussion of BRAF inhibitors, BRAF mutations specifically. I know that your study found an increased risk of radiation necrosis in patients that received concurrent radiosurgery and BRAF inhibitors, and yours isn't the first study to reflect this. Do you have any explanation for why this might be the case?
So we had a couple of hypotheses for this. So the first, these BRAF mutant melanoma patients, they are on targeted agents. These are relatively effective therapies. So what's possible is that some of the, unfortunately, we didn't have data providing info on non-checkpoint inhibitor systemic therapies. We do mention that as a limitation. So it's possible that some of these patients were on anti-BRAF agents and then switched to checkpoint inhibitors, and perhaps this could be related to a washout period between switching systemic agents and performing radiosurgery. But it's a little hard to validate that further because we don't have, we weren't able to collect data regarding anti-BRAF agent use. We saw in another study that we did that the patients who develop these imaging-defined necrosis changes actually do better. They tend to live longer, which is what we saw in our data set. So it just shows that, this imaging-defined radionecrosis endpoint is a very challenging thing to measure. And we need better technologies to actually measure that. So I know one thing, I think Dan has a trial open now looking at flucyclovine PET CTs to differentiate progression from radionecrosis. So it's definitely something we need to look into further.
Thank you. My next question sort of goes more towards the design of the study, and specifically, why was there a delayed immune checkpoint inhibitor group greater than 4 weeks versus concurrent radiosurgery administration? Why was there delayed versus concurrent?
Sure. So that was in line with, there's been several reports published over the years that have actually suggested that in patients who receive concurrent therapy, which is within that 4-week window, that they do better, that they have better local control, sometimes have better survival. They often have better out of field or distant brain control. But the concern is that when those therapies are given so close together, that it increases the risk of radionecrosis. So studies have shown, the Harvard group published a great paper several years ago comparing an SRS checkpoint inhibitor group to SRS alone. They didn't look at timing, but they showed that there was a much higher risk of developing symptomatic necrosis from melanoma brain mets in patients who get SRS and checkpoint inhibitors. So what we wanted to do, the question was, if we want to certainly give, we want the patients to have the best possible outcome. And in line with that, give the therapy within 4 weeks of one another, but at the same time, minimize the risk of treatment-related toxicities, which in this case would be the radionecrosis. So that's why we wanted to look at that 4-week window.
And to dovetail into that, do you have any explanation as to why there was a difference in survival between those two arms in the study?
So great question. So it wasn't exactly significant, but I would argue clinically very meaningful. I remember the p-value, I think, was 0.051, and it was 36 months versus almost 20 months. So some people will argue that sometimes you see a difference on some of these smaller studies because patients who get concurrent therapy probably have a better performance status, they have fewer comorbidities, there's less of a competing risk of death, but we actually didn't see that. The median KPS was 90 for both arms, and the interquartile range was the same. So one explanation, this is in line with other previous reports, this is a much larger series, but one prevailing theory is that the reason that patients tend to do better when giving the checkpoint inhibitor and radiosurgery within 4 weeks of one another is that it allows for enhanced anti-tumor immune responses against the tumor. And it allows for a more robust systemic response and a better way and a stronger way to fight the disease and control the disease. So we think that might be a possibility. So it's possibly related to immunogenic modulation.
I see. Thank you very much. Well, I think we're coming up on our time here. I want to thank all of our guest authors for taking the time out of their schedules to come and talk about their paper here, as well as Dr. Patel for coming and providing her expertise as our guest faculty. I want to remind everyone that this event is worth 1.5 CME. It's complimentary for all CNS members. And as always, this podcast will be available at cns.org. And again, this is the episode for the month of December. And I think that's all I have. Thank you all again very much, and we'll see you next month.